So good afternoon and welcome to our Healthcare Careers in Focus. Today's session is on the allied health professions, which is short to AHPs. We've got joining us today Julie, Hannah and Sophia, and I'm going to be handing over to Julie, who's our first guest speaker of the day. Thank you, Julie.
Thanks, Nikki. Yeah, my name's Julie. My background is a physiotherapist. I qualified in a long time ago now, 1997. So I worked on the front line as a physiotherapist for 25 years, and I worked for Hertfordshire Community NHS Trust. So I started off by doing a BTEC in health and social care, and then I went on to do my physiotherapy degree in Newcastle and got a job straight on qualifying at a local hospital, South Tyneside Hospital, as a junior. That was a rotational post and it allowed me to see lots of different areas of physiotherapy. So I worked in a stroke unit, I worked in a medical ward, a respiratory ward. I worked in a gym where people had operations on their lower limbs, and I also worked in an outpatient musculoskeletal outpatient department looking at backs and necks and shoulder problems and things like that. After doing that for a couple of years, I then moved into another rotational post, another level up, and did more along the lines of neurology. So I worked on a neurosurgical and neurosciences department in Newcastle, and that was seeing people who'd had acute head injuries, or they may have had brain tumours or other surgery to the brain. I also then worked in a community post, which I really, really enjoyed, because going out to see people in their own homes is really lovely, seeing them in their own environment and more relaxed. And it's really nice to be out and about visiting people in their own homes. So then I moved down to Hertfordshire and got a job as a physiotherapist in one of the community teams down here, gradually progressed to becoming a physio lead for one of the teams, and then have now moved into an alternative role. So it's nice to see that physiotherapists do have other opportunities in the future as well. And I now work in learning and development. But this session today, I'm talking about the role as a physiotherapist. So generally, as a community physiotherapist, you'd start at work, you'd log on to your laptop and check your emails, check any tasks or messages that have come through, and look at your appointments for the day. Inevitably, there will be urgent things that have come through, and you have to sometimes reorganize your day. You'd then be looking to collect any equipment or anything that you need for your visits that morning. You'd be going out doing visits either by yourself or with one of our assistants or with another member of the multidisciplinary team. You'd come back at lunchtime to the office, do some notes, do some more tasks. Afternoon visits, again, at the end of the day, you'd be doing notes and tasks. And there is a lot of signposting as well and referring to other services, because we do see the patients very holistically and do a full assessment when we visit them. So looking at the rewards, first of all, you can make such a positive difference to people's lives with physiotherapy. Seeing them, going from being really unable to do very much sometimes to then becoming independent again and moving forwards with their lives can be really rewarding. It's great to work as a team as well as an individual. It's never boring. People are challenging. Conditions that they have can be so varied, and so it's so interesting day to day. No 2 days are ever the same. And there's always opportunities to develop, and certainly within our trust we do have lots of opportunities, and at the moment we're looking at apprenticeships and supporting T-levels and other ways of becoming qualified. Some of the challenges may be that people may not be improving as you would want them to, so they could be acutely ill with an infection, or they could have a diagnosis that means that they're not going to improve, or they could just simply not be very motivated for whatever reason. So that can be a challenge. Situations can always be upsetting as well, especially if you are dealing with people that have a diagnosis and the outlook isn't good. There's never enough time. You always want to spend longer with your patients. But you are aware that there is a waiting list. That waiting list, we never get to the bottom of the waiting list. There will always be people waiting, and it's weighing up really spending enough time with people to allow them to improve, but also discharging as soon as you're able so that you can get on to seeing the next patient really that's waiting. So advice to my younger self would be, as Nikki said earlier, don't be afraid of asking questions. No question is ever too silly. And actually, it shows more about your thinking and how interested you are when you ask questions. Reflect on your actions. There's always room to improve. So as physios, we are taught to reflect on everything we do because there is always room to improve, and we can always, work better, work more time efficient. We can always make improvements. It's remembering it's okay not to know everything. Nobody knows everything. And it's just accepting that, because sometimes I think that the higher you move, you think you should know everything that everybody asks you, but you don't need to. It's okay to look things up. And just remembering to work hard and be kind and be compassionate and, treat others as you want to be treated, whether that's patients or other members of staff. So just looking at a case study of somebody that a community physiotherapist might typically see, I've given an example of a patient with a pubic rami fracture. So that's a fracture that can happen when somebody has a fall and it's in the pelvic area. It's extremely painful. I've never seen anybody with a pubic rami fracture that has not been in extreme pain. They have real difficulty weight bearing, and it's very difficult for them to walk. They could go from being completely independently mobile to really struggling to walk. And the fracture is most often treated conservatively. So that means there's no surgery that they do, no operation. You would be given pain medication and, given time to heal, which on average takes around 6 to 8 weeks. So if we take the case of Mrs. B, she's a main carer for her husband with dementia, and she fell over when she was assisting him to get into the shower in the morning. She would normally be independently mobile, but she did have a fall the previous year and broke her wrist, which she fully recovered from. She lives in a 2-story house and they have a daughter nearby. They're both retired. She drives a car and normally does all the housework and all the shopping and cleaning. So if Mrs. B turned up at accident and emergency, after diagnosing the fracture, they would be expecting the community team to visit her at home that same day, if not early the next day, to do a really comprehensive assessment. The hospital would give the pain medication, probably quite strong pain medication, and provide her with a Zimmer frame so that she can try and take some weight off her legs a little bit and reduce the amount of pain and enable her to get about. So what we call a holistic assessment, so looking at the patient, very comprehensively, doing a full assessment, considering everything when we go to assess them. Often it would be carried out by 2 people, whether that's a physiotherapist with an occupational therapist or with a therapy assistant, because if this person's in so much pain, they're not used to using a Zimmer frame, it could be unsafe just to have one person trying to assist them. The priority is trying to decide what is needed to help this person stay at home. And also pressure relief's also considered as a priority, because when somebody's going to be sitting or lying for long periods of time, it's very easy for pressure sores to develop. So it'd be looking at things that could be put in place to help reduce that. So equipment would be looked at for these sorts of situations in the early days. So to help with activities of daily living. So it could be raised toilet seats. It could be a handle on the bed to help them get in and out of bed. We've already mentioned the Zimmer frame, but there's lots of little things that can really help to support a person in those early days when they're in a lot of pain. Physiotherapists do tend to work with a lot of other professionals and are part of the multidisciplinary team. In this case, the physiotherapist would be concentrating on how to use the Zimmer frame, and as the pain reduces, hopefully progressing the walking using maybe elbow crutches and a stick, and then hopefully going back to walking independently. They'd also be considering the stair situation, maybe temporarily living on one level, but they would be wanting to help Mrs. B to get back upstairs as soon as possible. And they'd also be looking at appropriate exercises. And those exercises might be initially in the situation that she's in, on how, how to manage, but also as she improves, it might be looking more at balance and falls prevention. A community matron and a GP were asked to review the pain medication in this case and look at the risk of osteoporosis. So osteoporosis is where the bones are more fragile. If somebody has had, and in this case, Mrs. B had a previous fracture, it may be worth them doing tests to see what the risk of osteoporosis is and looking to see if appropriate medication and further management is needed. They also were needed to look at the pain medication because sometimes really strong painkillers can have side effects such as constipation or other problems. Social services and care agencies, and in this case the daughter, were all needed to help provide some support so that they could both remain at home. So ultimately, she recovered, Mrs. B recovered and returned to independent mobility and being able to drive her car. A DEXA scan was arranged, and that's to look at the bone density and look at the risks of osteoporosis, and then that management was taken further. Additional care package wasn't completely reduced, so some of that was kept in place, and I think it was seen that Mrs. B did need some help with her husband with his dementia. Ultimately, the community team responded quickly, and this response helps to prevent patients from needing to stay in hospital, and also it allowed her husband to remain at home as well, which if she'd needed to be admitted to hospital, he possibly wouldn't be able to do.
Thank you, Julie. Thank you for a quick whistle-top tour on what is a physiotherapist and what a day particularly looks like. So thank you for that. Our next speaker is Sophia. So Sophia, if you are there, I'll get your presentation ready.
Thank you. Hi, everyone. My name is Sophia. I am a dietitian. At the moment, I work within the community. So I also work in Hertfordshire Community NHS Trust, and I specifically work in the west of Herts. So that's me at the moment. So a little bit about my career journey so far. I am fairly new. I'm just starting off in my career at the moment, but I'll give you a whistle-stop tour about how I got there. So for A-levels at school, I did biology and chemistry. So I did have the science A-level background and music and Spanish as well, additionally. But it was really the sciences that allowed me to get onto my nutrition course, my undergraduate course at Nottingham. So I spent 3 years doing my nutrition BSc, and then I decided I wanted to become a dietitian at that point. So I really laid the foundation with my nutrition knowledge before deciding I wanted to work in healthcare, so where I could combine the two. So I then went and did my master's in dietetics at UCL in London, and I spent 2 years on that master's course with some studying and some placement combined. So my placements were very varied. They covered several different hospitals. I worked in the adult services, I worked in paediatrics, so I worked with children, and I also worked in public health. So it showed me the extent that dietitians can work within. There are so many different roles. After I graduated, I soon got my first role as a Band 5 dietitian in the NHS, which is my current role now. And I will soon be moving on to a paediatric role, actually. So I found the niche that I want to work in. So this isn't necessarily a day in the life, but I'll just quickly summarise what I do as a community dietitian at the moment. I'll try and also incorporate some roles and responsibilities of an acute dietitian as well, so a dietitian that works in the hospital, just in case anybody was interested. So community dietitians, we work with a variety of clinical conditions. Essentially, we work with people living at home or people living in care homes, and also those on the community rehabilitation wards, so the step down from the acute setting before they return home. So some of the clinical conditions that we work with can include nutrition support, which is our way of saying people who are underweight or people who have lost quite a lot of weight in a short amount of time. Some people may also need help with weight management as well, so helping to lose weight. That's not something that we specifically cover within our trust, but it is something that some dietitians focus on, helping people to lose weight. You can also get diabetes dietitians, and then we also work with people who have kidney disease, liver disease, IBS, inflammatory bowel disease, celiac disease. So there's lots and lots of different conditions that you would get to work with as a dietitian, and lots of different people you can help. We work with a large number of people as well, so from different backgrounds, different ages, different communities. So as I said, it's a very varied role. We also work with two different types of nutrition, or three really, but two on the screen here within my role. So we work with people who eat orally, as many of us do, but then there are also some patients who are enterally fed, which basically means they're fed through a tube. So that could be for several reasons. Some people aren't able to obtain the right amount of nutrition to sustain their weight themselves through food alone, and so they require a tube. Some patients are also fed through the veins as well, which is quite invasive, and there's very specific scenarios in which that would be required, but just to let you know that that exists as well. So we work through different routes of feeding. The crux of dietetics basically is we've got assessment and we've got review. So assessment, we would spend longer with the patients, we would get a thorough medical history, we would understand their medications that they're on, and then thoroughly look at their diet as well. So we would ask them to give us an example of what they would eat in a day, and then that would help us to help them and give them appropriate advice, so we can tailor our dietetic advice to what they normally have. And then we offer shorter review appointments as well. So during my clinics, I spend half the time assessing new patients and then half the time reviewing patients. Normally it's over the telephone in the community. Some people do home visits as well for those who aren't able to speak on the phone, and we also hold face-to-face clinics. As I said, I cover the rehabilitation wards and the nursing homes as well. And essentially, a lot of my advice covers food-based approaches, that food-first advice. I also work with people for dietary restrictions. So as I said, for specific conditions, they might need to remove certain foods or avoid certain foods from their diet. And modified textures as well. So for those who've got swallowing issues, we need to maybe change the way that their food looks and the way it presents in order to help them swallow. And then I've got at the end there the use of ONS, so that means oral nutritional supplements, which you might have heard of before if you have any experience. Things like Ensure is one brand, or Ames is another brand, of basically almost like protein drinks that really help people with their weight. And then lastly, I am a nutrition and dietetics awareness champion, so I do try and bring more awareness and recognition to the role. So some rewards and challenges, I'm sure they definitely overlap with some other allied health professions as well. What I find particularly rewarding about what I do is just helping people to improve their health. There's nothing more rewarding than working with a patient who was quite acutely unwell, or when they first come out of hospital, and seeing the growth and the development through reviewing them that they've made with our advice. So we work with patients over a long period of time, sometimes several years, and monitoring their weight consistently, we can see, or their blood values, whatever it is that we're reviewing them for, and just seeing how they've progressed. Also building rapport with patients, and also if you work in paediatrics, with families as well, and you really build those trusting relationships. It's also quite rewarding to be an expert within the nutrition field as well. So obviously having completed a nutrition-based degree, that's the same regardless of if you've completed a dietetics undergraduate degree as well, which is definitely an option. And there is also dietetic apprenticeships if you are interested. You also get to work within a very supportive multidisciplinary team, and also within the dietitian team itself. Some challenges can obviously be around people's health. People get quite anxious and quite emotional, particularly if people have been quite unwell. Some people also don't comply with the advice that we give, the dietary advice, which can be a bit of a struggle, but just means that we need to work harder through behaviour change, and working with them and understanding the individual patient to provide more personalised advice. So there are ways of getting around non-compliance, but it can be quite common sometimes. And then lastly, some of you might have seen online, there's a lot of nutrition advice. A lot of it tends to be incorrect or not applicable to everybody. And so we've really got to be careful with what advice we give to people, and making sure that it is specific, as I said. So yeah, sometimes we do have to challenge people on their ideologies and set the record straight. Some advice I would give to my younger self. So thinking back to when I was maybe in your shoes, doing my A-levels, or maybe even a little bit before, I knew I wanted to work in the medical field, and I knew I wanted to help people, but it really wasn't made aware to me other career options other than being a doctor or a nurse, which is also fantastic job opportunities, they're fantastic roles. But I really think if that's something you're considering, you should consider allied health professionals as well, such as being a dietitian. So I wish there were more opportunities available to me to be aware of that. So my second point there is just about attending as many career fairs as you can, and open days to learn more, and really just speak with dietitians and speak with any other allied health professional to understand their role in more depth. Then there's work experience opportunities as well, and don't be afraid to get in touch with people and ask questions. We are always happy to share more about what we do and answer any questions. There's no silly questions, so don't be afraid to reach out. So this is just a brief case study. It does get a little bit wordy, but I'll try and run through it quite quickly. This is a basic nutrition support case study. So if you were to ever become a dietitian or consider becoming a dietitian, this is something that you would see very often, particularly in your graduate roles. So essentially what I'm doing at the moment. It's a very standard case. So this is about an 80-year-old female. She lives with her husband at home, and the husband helps to prepare the meals for her. She's got a carer coming in once a day, basically at 11 a.m, who sometimes helps with the meals as well, and she is mobile on her feet. This is some of the information that we would like to gather either just before the consultation with the patient or during the appointment. So as a dietitian, we always look at height and weight and BMI as well. It gives us just a ballpark figure of where they are in terms of their nutrition, and whether we need to provide some nutrition support advice or weight management advice, and if they're a healthy weight or if they've lost quite a lot of weight. So this lady has a BMI of 16.9, which is considered underweight. We don't have information about how much weight she's lost, and if she's always been that weight, but regardless, she is underweight at the moment. looking at her past medical history, which tends to be within referral forms if we're lucky. However, we might have to obtain that from the patient themselves or from the carer or any family members who are there. So it just depends. Her past medical history is she has dementia with a few other things going on as well. So she has bipolar disease, a lung infection previously, hypertension, hypercholesterolemia, and GERD. So there's a few different things going on there. Bowels and skin are the two other things we tend to look at and monitor because they can be a really good indicator to us for nutritional status and whether they need any dietary support for their bowels or their skin. So her bowels are opening regularly and she doesn't require any laxatives, which is fantastic. And her skin shows no pressure sores. All her pressure areas are intact. So now we're looking at the diet. So once we've got the more clinical impression through her weight, bowels, and her skin and her past medical history, we are going to look at what she eats. Normally for breakfast, she would have a Weetabix, just one, with some milk or maybe a boiled egg. She wouldn't have any lunch, and she would maybe have a very small evening meal, maybe half of a portion with a pudding. I've got additional there as well. So she is prescribed some drinks. As I said, the oral nutritional supplements. One example is Fortisip. So that's just the name of a brand, but that would have been prescribed through the GP. Just some additional points there. She finds some things slip down her throat easier than others. So for instance, a creme caramel or something that's maybe a little bit softer. She likes milky drinks, which is great if we're trying to help her with her weight, but she can't make them herself. She struggles with that, and that could be relating to the dementia. She does have some instances of choking and coughing as well on certain foods and drinks as well, and so that raises some alarm bells for us. And then she's managing one Fortisip a day, as I said before. She's got just one of them, but feels like she could manage two. So in speaking with this patient, this is what we gathered. So the patient informed us that in 2016, she was diagnosed as pre-diabetic. So she lost a lot of weight at that point fairly quickly. So we can see she lost over 10 kilos in weight, which is quite dramatic of weight loss. Essentially, with adults, we like to see a nice, healthy, stable weight within the healthy weight range. We don't like to see any big drops like that, of course. So we're thinking, why did that happen? She's unsure what happened to her weight at that point, but she has lost a further stone over the last 6 months, so she's lost even more weight. So we've really got to think, what can we do dietary-wise to help her now that her weight is even lower? She lost her appetite at the time, but doesn't know why, as nothing significant happened. So this is what we're going to do to help this lady. And this is, as I said, a very standard case of nutrition support. So we do have some questions that we would like to inquire as well before we give this advice. Particularly, as I said, about the choking, we would like to take that up further. We'd like to ask what kind of foods that happened around. Is it more tough foods, or is it very thin fluids? If, for instance, she has like a cup of tea or a glass of water. But essentially, I know we don't have all that information, but our advice would centre around the following. So the first thing is food fortification. You might know what that means already, you might not. Essentially, we would be adding things to this lady's meals, to what she is having, to add even more calories, to boost the calorie content. So we're thinking of things like milk powder, cream, butter, cheese, even cream cheese, olive oil as well, which has got healthy fats as well, avocado, again, for the healthy fats. So peanut butter or other nut butters as well, just finding ways to boost the calories of what she is already eating. And that can be done to more pureed foods as well. So we're thinking if she ever has anything like a yogurt, or if she ever has like mashed potato or porridge, or even in her Weetabix in the morning, we can add more milk powder to the milk that she's already having, or if she mashes her Weetabix up to boost the calories to help her gain some weight. We can also offer her some high calorie snacks, and they can get that in maybe more convenient sized packs. So that we're thinking things like biscuits, we're thinking things like cake, just high calorie snacks. Cheese and crackers are fantastic. Yogurts, as I said, custard, rice pudding. But again, we do have to be wary about the choking. And then lastly, on the screen, we've got some oral nutritional supplement drinks. So in the hospital setting, we can give these drinks, these supplement drinks, more readily. They tend to hand them out quite a lot. In the community, it's a bit of a different story. So we can't prescribe these drinks without very clear, significant reasoning. Some of the drinks can also be thickened. So if this lady requires a thickened drink to help prevent any more choking, then we can give relevant ones then. Alternatively, in the community, we do like to give, or we do like to suggest making something like a Horlicks or an Ovaltine or a Nesquik even. Some kind of homemade milkshake is what we like to offer instead. But it really depends on the case. So for this lady, I know she was having Fortisip, which we might be able to increase to twice a day to help boost her weight, but we have to see. So the next slide is about multidisciplinary working, and this is where I'll elaborate a little bit about what we're going to do about the choking situation that she's having and the coughing. So immediately I would think we need to refer her to a speech and language therapist for assessment. So what they can do is they can actually assess her swallow according to different foods, different thicknesses, different textures of food, and see what levels she is able to tolerate. So if she needs to stick to purely a pureed diet or a mashed diet, or thinking about fluids, if she needs to have those thickened fluids, as I said. So really we'll be referring them on and working with the SLTs. Then we've got the GP as well, who we will liaise with regarding the prescription of her supplements. So that might need to change if the speech and language therapist has told us that she can only have thickened fluids for her swallow. So we would need to be in touch with them and write letters to them. She may also need to see a physiotherapist or an occupational therapist. Again, we don't have enough information in this case study to be able to tell exactly, but if she has any mobility issues or if she needs any more support around the home to prepare food, or I know she's got her husband there as well, which is fantastic, but if she was living independently, that's something we would have to think about. And then, of course, we would ideally talk with the carers and the family members to see what level of care they can provide for this lady. And this is just my last slide here. So if you are interested in dietetics and becoming a dietitian, we do have an open day coming up at the end of October. So if you do live in and around Hertfordshire, we have an open day here in St Albans. This is just some information on the slide. Where you can just spend the day learning more about what we do, seeing some samples of these supplement drinks firsthand, and just running you through, giving you some mock consultations of what it would be like, some observation really, and talking with the dietitians in our team. So we've got some contact details there if you're interested in that. Thank you everyone for listening. I think that's my last slide, and I'd like to invite any questions. I don't know if anyone's put anything in the chat. There's one question in the chat there.
Go for it. Yeah, go for it.
So do you have a patient group that you particularly like to work with, and why this group? I think a lot of figuring out what you do like, especially, you know, no matter what your career is figuring out what you don't like. So a lot of people, as I said before, can be quite anxious around their health, particularly those maybe with IBS or some gastro conditions. So that can often make anxiety worse because they don't know when their symptoms are going to happen. And then the anxiety makes the symptoms worse. So it's one of those negative spirals. It's the same really for any condition as well. I particularly like working, as I said, with pediatrics. That's my next role that I'm coming into very, very soon. And I like that because I really like working with families, and I like helping families as a whole, the whole unit, to improve children's health, and making sure that they're thriving and growing appropriately and proportionately. So that's really why I enjoy that.
Okay, thank you, Sophia.
Thanks. I think there's one more question as well. Shall I go ahead and answer?
Yeah.
Thank you. To work within a career like this one, would you say that it is helpful to take a science-based A-level? Absolutely. You don't even have to do A-levels. I know there are many routes into dietetics. As I said, you can do a degree like I did or a master's like I did, if you realise after your undergraduate degree, or you can do an apprenticeship. And I believe they take BTECs as well, and other qualifications. I do believe it has to be science-based, but I guess it just depends on the course as well. So you would have to have a look at the different universities that offer that course. But yes, I'm pretty sure it would have to be science-based or food science-based. I think they might allow that.
Thank you very much.
Thank you.
And if there's any other questions, we can pick them up after. So we are now on to our last speaker of the day, and this is Hannah, who is an Operating Department Practitioner. Thank you, Hannah.
Thank you. So this is me. My name is Hannah, and I am an Operating Department Practitioner, or an ODP as we are more commonly known. But if you have never heard of us, I won't be surprised, because not a lot of people have heard of us. So I work at the Princess Alexandra Hospital NHS Trust, and I specifically work in theatres. We have around 11 or 12 theatres here, and we cover main theatres, a day unit theatres, and maternity theatres. Next slide, please. So my career journey, I never knew what an ODP was, and it was by chance that I discovered it. So I was at college and I was doing a BTEC health and social care course, because I did know at that age that I did want to help people, and I originally thought that I wanted to be a midwife. So after my health and social care course at college, I then applied to go to university as a midwife. And unluckily or luckily, depending how you look at it, I wasn't accepted. So, and I got told that I needed to find experience in the NHS. So I applied for HCA jobs at my local hospital. That was on the wards, HCAs in theatres, which is what I then got accepted for. And they don't call a HCA in theatres a HCA. It stands for healthcare assistant, but in theatres they have what they call a theatre support worker, and that was the role that I was given. And I loved it. I really, really loved it. I was thriving, and I got told that theatres is a bit like Marmite. You either love it or you hate it, and I loved it. And that is where I discovered the role of an ODP, and I was obsessed, and I knew, forget the midwifery, an ODP is what I want to be. And considering we work in maternity and we do elective and emergency C-sections, we still get a part of that. So it was absolutely perfect for me. So after 2 years, I applied to university and I got in, and I studied for 3 years, and I got my degree, and I qualified last summer. Somerset 2023 is when I qualified. So a day in the life of an ODP, there are 3 areas within theatres that an ODP can work. So you can work in 1 or 2 or all 3 of the areas. You can choose to do them all, or you can specialise in one area. So the 3 areas are anaesthetics, scrub, and recovery. So if you work in anaesthetics, you will be preparing the patient for their anaesthetics, so being put to sleep for their procedure, and you will be reassuring them, because often patients are quite anxious, because it is the whole idea of being put to sleep, not really know what's going on, it's the unknown, and you do really have to be there for them, and tell them that you are going to look after them and you're going to do the best for them, and it's going to be okay. We have expert knowledge and training of airway management, because when you are put to sleep for a procedure, we need to pop an airway into the patient's throat to breathe for them. And we also have excellent knowledge about drugs and pharmaceuticals, because obviously drugs are required to put patients to sleep, and we use drugs to help monitor and support the patient's heart rate, blood pressure, and all things like that. So we are also responsible for checking and maintaining specialised equipment, like our anaesthetic machines, which are used as ventilators while people are asleep. We also have lots of other specialised equipment, but I could be here all day talking about them. If you work on the scrub side, you will be getting all sterile with your gowns and your gloves, and you will be dealing with all of the surgical instruments, working with the surgeon and your team of other people. So when they ask, for scalpel, you give them the right instrument at the right time, and you are responsible for all of the instruments, the swabs, the sharps, and you are accountable to know where they are at all times and that all the counts are correct, so that nothing gets left in the patient at the end of the procedure. And if you work in recovery, it's after the operation has finished, and it's when you're waking the patient up, you're making sure that everything is safe, you're making sure that the patient recovers well, and it's transitioning back from their procedure to then either going home or going to the ward, because they're then going to have an inpatient stay. So I would say an ODP job is highly, highly rewarding. It does come with its challenges, but when you get your really anxious patients and they want the procedure, but they're just so scared to have it done, and you reassure them and the procedure goes well, and sometimes it's instant. As soon as they wake up and they see you, that person who was there holding their hands while they went to sleep, sometimes they're like, oh, like, thank you so much for helping me. And you're like, it's okay, don't worry, relax. Like, you're not really awake yet. But yeah, that feel good feeling that you get at the end of your shift, knowing that you helped do 2, 3, 4 or 5 surgeries that day, knowing that these are conditions that people have been struggling with and waiting a long time for their surgeries, that, you've helped them all be better and to recover from their conditions. Also, making a difference with students. Now, we have a lot of students in our department, not just student ODPs, but also we get student nurses, we get medical students, we get paramedic students that come in and that learn from us and our skills. And it's nice to know that you're passing those on to other people and you're helping shape the future workforce of the NHS. And achieving your goals and furthering your aspirations. So when you qualify, my main goal was just to get through a shift. But as I've qualified longer and my working experiences have gotten more and more, I want to be more involved with helping the students, and I've made a couple of quality improvement things. And that's the beautiful thing about it, is you can come to work and you can help do all the surgeries, but there's so much more going on that you can get involved with and that you can help with. The challenges are, of course, not everyone always has a good outcome. Sometimes you do get the bad outcomes and it can be quite emotional, but as long as you know that you've done all that you can for your patients and that you've all tried your best, what will be in some cases. And it's knowing how to manage that, especially the stress of it. You do have to know how to manage your stress, because it can be a very stressful job sometimes. But having good working relationships with the people that you work with, and knowing where to go for support as well, and how to manage stress, I'd say is a big plus. Not even just in my job, I say all NHS jobs are stressful, and knowing how to manage stress would be a big positive. Advice to my younger self would be to research healthcare careers more, because I was very much in the mindset that there was just doctors, nurses and midwives in a hospital. I had no idea just how many people actually worked within the NHS. And like I said, it was just chance that I stumbled across the ODP role. So I would definitely recommend, for me, when I was at school and college, to recommend researching them more. And also to try and get some work experience, because they do offer work experience now to those aged, I think, is 16 and 17. You don't have to be 18 in some areas anymore. You can get work experience. And it is good, because if I did my work experience here and I found the ODP role, I probably wouldn't have gone down the route of applying to be a midwife. Or you can find something and you say, well, no, I wasn't really sure about that, but I'd like to go and have some more experience in that area because that really interested me. And it just gives you such a more wider range of knowledge of how many people and the job roles are actually involved in the NHS. So for this case study, we have a 70-year-old male patient with no known drug allergies who has recently been diagnosed with bowel cancer. And he has been scheduled on the emergency list for a laparotomy procedure. Now, in my theatre department, we have 7 theatres up here in main theatre, and one of them is a 24/7 emergency theatre. It can be from people who have come in through A&E, or for patients that are already on the wards that an emergency has come around and actually this needs to be done sooner. They can't wait to be put on an elective list that is a planned list where people have waited for a long time. So the patient was brought in by ambulance yesterday to A&E with symptoms for 3 days of abdominal pain, nausea, vomiting, constipation, and no intake of food, but is managing to drink water. The patient was investigated in A&E and was diagnosed with a bowel obstruction. So the bowel cancer that he has recently been diagnosed with, he has a tumour which is causing a blockage in his bowel, so nothing is able to pass through. So subsequently, he was then booked for theatre on the emergency list, and the emergency theatre operates by the amount of cases that are booked and the severity of the cases that have been booked, and they work on a priority basis of quite a few things. So they'll look at how sick the patient is, or how sick all the patients are, and they'll kind of look at who has the more emergency, like the higher the emergency, and the sicker they are, they'll be put first on the list to be operated on that day, and we'll go by a priority basis. So a bowel obstruction can be fatal if it's left untreated, and it can cause, unfortunately, a patient to pass away. So this patient would class as quite a high priority on the emergency list. So the treatment for a bowel obstruction for this gentleman would be a laparotomy procedure, which is used to fix a bowel obstruction. This is a major procedure because the patient is going to have a very large incision right from their chest all the way down to the groin area. And obviously we're going to be operating on all of his bowels and everything. It's going to be quite a lengthy major procedure, very invasive. So I've done this as if this was me working, because like I said, ODPs can work in the 3 areas, and I work both on anaesthetics and scrub. So I've done this as if this was my day in the life. So if I was on the anaesthetic side looking after this patient, now the more complex the procedure, the more support the patient is going to need from us anaesthetically. So he will need an endotracheal tube, which will go past the trachea in the patient's throat, and we will use that to ventilate him throughout his procedure. He will need an arterial line, which is similar to a blood pressure that goes on their arm, but it's a lot more invasive. So it is a line that will sit inside, usually in the wrist on the radial artery, and the line will sit inside the artery to monitor their blood pressure. They will also have a central line, which is commonly in the jugular vein in the neck, that gives us direct access to the heart for the vein, so pumping drugs through. It will take a lot less time, because if it was the vein in the hand, it would have to go around the whole body to get to the heart, whereas this is situated very close. We will also need to temperature monitor this patient. We will need to monitor the fluids that are going in and out of this patient. So any IVs that we give him, any fluids that we give him, and then any bloods that we give him if he needs bloods. And then coming out, we will monitor him with a catheter and obviously blood loss and things like that throughout the procedure. He will need cardiac monitoring, and also we would have to take into consideration post-op pain relief and management, because he's had a really big incision. He's had all of his insides messed around with. So when he wakes up, his pain is going to be quite high. So we will have to think about things we can put in place for him that will help with his pain relief. Now, if I'm on the scrub side and I'm scrubbing for this procedure, again, the more complex the procedure, the more instruments and the more sets we're going to need for it. So as the scrub person, I will have maybe one of our larger sets that can have like 100+ instruments on it. We will need a lot of swabs and a lot of sharps, more than what you would for a smaller procedure. And then I have to be in control of everything. I have to know where everything is at all times, which can be quite challenging. And also, the bigger the procedure, sometimes the more surgeons there are to work with, because you can have a consultant surgeon who will be scrubbed, and he will have a junior and a registrar, and sometimes even a medical student as well. So there will be a lot of people doing this surgery that will all need things from me. So I have to be quite on the ball with my job of who I'm giving what instruments to. Now, the patient's journey through theatres, they will meet a lot of people from a lot of different professions. So, for example, if we start from the patient's journey in A&E, he will have met the consultant surgeon down in A&E, because he would have assessed him and diagnosed him and said, this is your treatment plan, I'm going to be operating on you. And then if he had any resident doctors with him, they would have met him at that time as well. And then when we get the booking form and we're ready to send for this patient, we send our porters to go and collect them from A&E, that will then pick him up, put him on a trolley, and then they will bring him to us in theatre. So that's when they would meet the porters. And then when they arrive to theatre, they would meet the ODP. We'd greet them, we'd check them in, check all of their details. And that is when they will meet the anaesthetist as well, and when we put them off to sleep. And then the theatre nurses, the HCAs, all part of theatre, they'll meet the patient on their journey there as well. And then when they're awake in recovery after the procedure, they'll meet recovery nurses, pain nurses, physiotherapists, medical students. The list can go on, but that was just everything that came to my head when I was doing this presentation. Multidisciplinary working is a fundamental part of the NHS, especially working in theatres. You need to know and have the skills to be able to work as part of a team. And it is, I'd say, one of the most essential skills, along with communication, otherwise the system just doesn't work. And as an ODP, you also need to know how to work on your own, but as part of a team as well. So our gentleman for the laparotomy, it was a 4-hour procedure in the end, and the team was successful in removing the tumour that was blocking his bowel. And the outcome was that the patient was given a stoma bag. So what happened was, where the patient had the tumour in the bowel, we ended up having to remove, I'd say, a big portion of his large bowel. So, and in order to do that, we had to then give him a stoma bag where the bowel is attached to the skin on the tummy, and then that is when all the feces will come out from, and he has a bag on there to collect all of that. So the patient was stable throughout the procedure, everything went well, and afterwards he would need a higher level of care than the ward can offer, so he got transferred to the higher dependency unit and is recovering well. So a recap, because I've given you quite a lot of information about what an ODP can do, and I understand that this might be the first time you're hearing of what an ODP is. So we predominantly work in theatres, either on anaesthetics, on scrub, or in recovery. And since the pandemic, the COVID-19 pandemic, it has become well known of how transferable an ODP skills are to other areas. So as quite recently, ODPs have been branching out to both ITU and to A&E and to other areas. It is a 3-year degree at university, and where you will study quite a lot of topics within this degree, as pharmacology, anatomy and physiology, ethics about healthcare, and loads of things like that. It is a very, very rewarding job, but you will be prepared to work very hard, and every day is different. No day is the same. I can see that there is a question in the chat box. What is the difference between a theatre nurse and an ODP? So a theatre nurse has done a nursing degree. An ODP has done an ODP degree. So a theatre nurse will be able to do the scrub role, and that will be it. Or they can do recovery nurse, and that will be it. They don't tend to really cross over. And if they wanted to do anaesthetics, they would then have to go back to university and do a top-up course to be able to do anaesthetics as well. And obviously, even if you're a theatre nurse, you can go and work on the wards as a nurse as well, whereas ODPs don't tend to do that. We're a more specialised course than that. We're kind of based for theatres and similar areas as like ITU and A&E. Is there any other questions?
Just while we see if there are any more,
Yeah.
Hannah, I just would like to say thank you. I've been in the NHS many years and actually didn't know anything about ODPs until a couple of years ago. So like you say, it's one of those that has an incredible important job, but you may not necessarily know about it. But thank you for coming along today and talking to the students. I'm sure that they found
thank you for having me.
interesting.
Thank you for having me.
Perfect. So this is our feedback form. So please, students, if you could just scan the QR code, take a quick minute to fill in some feedback. Like I say, positive, negative. It helps us plan our next webinars that we have for yourselves, where we'll be covering lots more careers in the NHS. But thank you for coming. Like I say, thank you for taking the time to fill out the feedback, and we'll see you for the next session. Thank you.